Well, good afternoon, everyone. My name is Barry Sarvet, and I'm the statewide medical director for MCPAP. And I wanted to welcome everyone. Thank you for joining us at our monthly MCPAP clinical conversation session. So today we are going to be talking about anxiety disorders, and this is part of our series of sessions that are designed to train people to our MCPAP practice guidelines. So as you may know, we have a set of algorithms and what we call clinical pearls documents, which are really designed to help pediatric primary care providers to treat patients with what we consider to be the most common psychiatric illnesses, and we have updated our anxiety disorders algorithm, and we're really pleased to have Dr. Bruce Waslick to teach us about them. So before we get started, just a couple of housekeeping things. We're recording the session, and as always, the recordings are available on the MCPAP website, which is, by the way, at www.mcpap.org. You can also get a copy of the slides on the MCPAP website, which we post shortly after the presentation. And of course, you can download the algorithms and the clinical pearls documents on the MCPAP website as well. So we will take questions, and the way to ask a question is to type it into the question box during the presentation. Dr. Waslick has graciously agreed for me to interrupt him if needed during the talk, if there's a question that's relevant to what he's talking about. And we're also going to save time at the end for questions that come up that aren't really sort of part of the flow of his talk. And please, if you could take a moment to fill out the survey at the end. We look at all the responses and we find them really helpful so that we can make better presentations over time. Not that we need to make Bruce's presentation any better, because it's going to be great. So let me go ahead and introduce Bruce. Bruce is the chief of child psychiatry here at Baystate Medical Center. He's an associate professor of psychiatry at UMass Med School and has an adjunct associate professor rank at Tufts University School of Medicine. He actually is the medical director of our outpatient psychiatric program, in addition to his chief responsibility. And he also is the co-medical director of the Central Western hub of MCPAP with Dr. Yael DeVere from UMass. He went to medical school at Tufts. He did his undergraduate degree at UMass in Amherst. He did his residency in general psychiatry and child psychiatry at Tufts New England Medical Center, and also did a research fellowship at Columbia. He actually was the principal investigator for the Columbia site of a large multi-center trial called the TADS trial, which is something that was really a landmark study guiding the treatment of adolescent depression and addressing the use of SSRIs in the treatment of depression for adolescents, as well as cognitive behavioral therapy. And he also actually was involved in the CAM study, which was also a multi-site study, a clinical trial in treating child and adolescent anxiety disorders. So Dr. Waslick is a wonderful clinical educator for our residents and our fellows at Baystate. He's been involved in MCPAP for many years. He's really a thought leader in pediatric psychiatry in many ways, and is a wonderful colleague to me. So thank you, Bruce, for agreeing to present again. Bruce is returning after his presentation a couple of months ago on depression. And go ahead and take it away.
All right, thank you, Barry, for that wonderful introduction, and good afternoon to everybody. We are going to go through the a clinical algorithm for pediatric and adolescent anxiety. And looking at it, we haven't updated a ton in terms of the content, but it's always good to go through things every once in a while just to make sure we're staying up to date. And the most important thing about these clinical guidelines is that they are relevant to primary care providers. So hopefully it'll be of use to go through the guideline again and just refamiliarize ourselves with different aspects of caring for kids with anxiety issues. So just an overview, I'm going to reintroduce the topic of MCPAP clinical algorithms. People who've been to clinical conversations with different MCPAP clinical algorithms have probably heard a little bit about the origins, but I'll refresh people's memory about where they're coming from and what's the big ideas behind producing these MCPAP clinical algorithms, and also why go to the trouble to update them every couple of years. We'll talk about the MCPAP pediatric anxiety clinical algorithm, and then hopefully we'll have some time for questions and discussions at the end. So again, the MCPAP clinical algorithms, the overall purpose is really to create practical clinical guidelines for primary care providers when dealing with common mental health problems of children and adolescents. That's the idea behind them. We want them to be helpful and useful for you guys, so that when you're dealing with a kid who has a particular problem, you have at least a starting point, a framework to begin to understand what's going on and try to offer some help with the family. We don't expect every child with an anxiety problem, especially serious anxiety problems, to be evaluated and treated by primary care doctors, but the families are going to seek out primary care doctors often as a first place to go for help. So we want you guys to feel confident that you'll at least be a good resource for the family moving forward. The guidelines tend to encompass several commonalities. So we start with screening procedures. And generally, primary care doctors are doing some kind of behavioral health, mental health screening for kids coming in for well child visits. So we start with the screening procedures. We move from screening to evaluation. That's a very important step. When I teach our residents, I say, make sure you've done a good evaluation and you're comfortable with a finalization of an evaluation before you start moving on to treatment planning. So I consider the evaluation that folks are going to be doing after the screen to be a very important part of this entire process. Once the evaluation is completed, moving on to thinking about treatment planning considerations and the MCPAP clinical algorithms, because we don't necessarily expect that primary care providers or the primary care practice is going to be providing most or all of these psychotherapy or psychosocial interventions, but could be definitely involved with provision of medication treatment for kids who warrant it. We've included a set of medication treatment guidelines with all the MCPAP clinical algorithms. At least in the western part of the state now, more and more practices are starting to have integrated behavioral health providers in their practice. So the practice itself is now taking on quite a bit of the psychosocial intervention, psychotherapy, and working collaboratively with primary care providers in terms of providing really good care for kids with anxiety and mood symptoms. We'll focus on anxiety for this presentation. So in terms of the content of the clinical algorithms in general, the content is developed really to be most helpful for the primary care provider in regular primary care practice. The content includes procedures that can be performed in all algorithms in the context of regular primary care practice. The content recommends the use of standard, well-validated clinical rating scales that can be used in clinical practice. We do recommend measuring things, just like you measure height and weight and blood pressure and pulse. Measuring symptoms of anxiety can be very helpful and informative And we have good scales that we're going to recommend for measurement and clinical utilization. And finally, the content recommends the use of medication guidelines, all suggesting evidence-supported first-line medication treatment for mental health conditions commonly treated in primary care. So anxiety is probably the most common of all the psychiatric syndromes that are seen in primary care. So having some familiarity about some first-line medication interventions, we think will be quite useful for primary care providers as they move through their practice on a day-to-day basis. The process of developing the algorithms, we follow a common process. So in terms of first conceptualizing and choosing which algorithms we think about, it's really through a consensus process. We have a group of medical directors that meet on a monthly basis through MCPAP. We talk about possible clinical algorithms. Again, we think about conditions that are commonly seen in primary care and conditions that can be reasonably evaluated and treated in primary care as a good idea behind starting with a clinical algorithm. Really rare conditions and specialized treatment resistant conditions, we're not thinking that those are necessarily going to stay with a primary care provider. Those are going to need much more specialized treatment. So we're focused on conditions that are often seen and potentially can be treated in primary care. So we start with sort of a clinical consensus from a conceptual standpoint. Some initial clinical guidelines have actually been developed by Heather Walter and her colleagues at Boston Children's Hospital for some of the primary care practices supported by Boston Children's Hospital. So we're not starting from scratch. The anxiety disorder algorithm was not completely from scratch. We started with some work that had been done by Heather and her colleagues and had been brought to the PPOC practices. But then we've modified them through, again, a clinical consensus process, looking for evidence-supported recommendations related to screening, evaluation, and treatment intervention. The first 3 MCPAP algorithms that we brought out were depression, anxiety, and ADHD. They're also the first 3 that we're doing sort of a 3-year update on. We've already presented depression and ADHD, and now we're representing anxiety at this point. So what are the applications of the clinical algorithms? Well, there are several. So we're hoping that the algorithms are going to be helpful in training primary care providers in basic evidence-supported tools and procedures for the mild to moderate, relatively uncomplicated forms of mental health problems that can be reasonably handled in primary care. So we're not talking about the kids who are severely ill or severely functionally compromised, or kids who've been through a bunch of different first-line treatments and are not responding. Those are generally going to end up in specialty care. We're talking about more of the mild to moderate, relatively uncomplicated forms that we do think that primary care providers can be quite effective in evaluating and treating. It's also another application of the algorithms is more of an internal application. We want our MCPAP consulting teams to provide consistent training and guidance to primary care providers, both during phone consultation as well as face-to-face consultations across the state. So that if a primary care provider in the eastern part of the state refers somebody for anxiety for evaluation at one of the eastern teams, if the condition is similar symptoms and similar functional compromise, then we're hoping that the consultation and the recommendations that come out of the consultations will be consistent across the state, so that we don't want different recommendations coming out of different teams. We're hoping that the MCPAP clinical algorithms will help train us internally so that we're more consistent in our recommendations to primary care providers. It's actually become important because now we've moved to telehealth, and that sometimes when the Western team is overloaded with referrals, which happens, or the Central Mass team is overloaded, that we're actually in a position that some of our kids in Western Mass could see for a telehealth consultation MCPAP teams in the eastern part of the state. That's been a reality. So we're hoping that the primary care providers in the different regions of the state will get consistent recommendations regardless of which team is actually doing the consultations. Again, to repeat, the algorithms are likely not going to be the best starting point for the severely ill, treatment-resistant, or highly complicated presentations of mental illness in primary care. They're generally going to end up being referred to psychiatry, specialized psychiatry care. You may need to recognize them and evaluate them, but you wouldn't necessarily be expected to be involved directly in the treatment for these kids. They're going to go to specialty care. And whenever we talk about the clinical algorithms, the presumption is that you can use the clinical algorithms to help guide you all, but you should make liberal use of the MCPAP phone consultation and face-to-face consultations for things that are not straightforward, for complications, or for help with any kind of clinical decision making. So we have the clinical guidelines, but they are not meant to replace the phone consultations or the face-to-face consultations for things that are particularly vexing or troubling for primary care providers. All right, so the MCPAP anxiety clinical algorithm was actually the second clinical algorithm rolled out by the MCPAP teams 3 years ago. We're going to provide some clinical guidelines for primary care providers in terms of screening for anxiety disorders in children and teens, help with understanding diagnostic evaluation procedures. We'll talk about some different treatment planning considerations, and then we'll also be talking about initial medication selection, as well as medication management for kids who are taking medications for anxiety. And yes, we do think, and we know that it happens, that primary care providers can effectively provide good, high-quality medication treatment for kids with significant anxiety problems. This is what the guideline looks like. I'm not going to go through it in detail here. We're going to break it down. But in general, this is what it looks like. It's meant to be sort of like a workflow sheet. So starting with the initial screening visits, and then doing some evaluation, and then deciding whether somebody is meeting criteria for subclinical to mild anxiety, moderate anxiety, severe anxiety, and then go through some considerations related to management. Screening and evaluation procedures up in the top bubble, help with clinical decision-making procedures in the middle area, medication selection support. We're going to go through all of these things in detail, and also discuss some issues related to follow-up monitoring support. And actually, we'll talk a little bit about termination of treatment when kids are really doing well for an extended period of time. Down the bottom, you can't see it so well, but we do want to acknowledge that the starting place for the MCPAP anxiety guideline for primary care providers was the work by Heather Walter and her colleagues at the Department of Psychiatry at Boston Children's Hospital. So again, we say thank you to Heather and her group for getting us started. And Heather has continued to work with us and is part of the medical directors group for MCPAP. So she's not only provided the starting place for us, but also has been with us all through the development of the algorithm. Okay, we'll move into the screening and evaluation procedures next. So again, we're sort of assuming that the first starting place is when we do a behavioral health screen at a primary care visit. And there's two places where we could be involved with the primary care visit. One might be a well child visit, an annual well child visit. Another might be a a selected visit, coming in particularly for a mental health reason, but we'll use as sort of the prototype sort of screening done at a primary care well child visit, where you're screening for all kinds of different behavioral health problems. But anxiety is, again, one of the most common ones, and maybe one of the ones that you are likely to find upon screening. Many practices we know are using the pediatric symptom checklist, the PSC-17, and it's a great screening tool for practices because it has different cut points indicating total problems at the level of concern, as well as specifically screening for both internalizing as well as externalizing symptoms. Internalizing usually reflecting mood or anxiety symptoms, externalizing symptoms reflecting more problematic behaviors. And so they come in, if you do the screen, if there's a concern for anxiety on the screen, we'll be recommending evaluation, and also helping with guiding treatment selection and treatment decision making moving forward. We're always going to screen in cases of positive screens for anxiety or mood symptoms. We're also going to screen for red flags indicating possible suicidality or other serious problems, physical harm to others, significant substance abuse. And those are going to certainly affect what we're going to recommend for treatment interventions. And if there is concern for imminent danger, primary care evaluation is not going to suffice. We're going to have to get those kids in to see a crisis team or a mobile crisis team for emergency psychiatric assessment. So we're going to screen, and then we're going to move into evaluation procedures. We're going to screen kids for very serious problems that require psychiatric emergency evaluation, and then move forward from there. And throughout this entire process, if there's any questions or concerns, you can make use of the MCPAP phone consultation whenever you feel like it's needed. So this is the PSC-17, and as we talked about, there are different scales. There's the internalizing scale, there's the ADHD symptom scale, there's the our subscale, there's the externalizing subscale. So you're screening for actually quite a bit of different types of mental health problems. The internalizing subscale is going to be a combination of mood symptoms and anxiety symptoms, and a subscale score on the PSC-17I greater than equal or 5 means that the child is screening positive for internalizing symptoms. Now, if you look through this scale, most of the internalizing items are related to mood. If you look down at number 15, that's the primary anxiety screener. That's the worries a lot screener. And these are graded at never, sometimes, often. So when you do a PSC-17 screener and the internalizing subscale is 5 or higher, and you're worried about anxiety, then look at item number 15 and see how strongly that item is rated in terms of anxiety symptoms. Again, this is the screener. Other families might be coming in specifically with problems related to anxiety that they're going to want the primary care doctor to at least initially evaluate and give some recommendations in terms of treatment. So once we've got a positive screen, we're talking about doing a more substantive evaluation. And this is where we move into using measures, empirically supported measures for helping determine the initial diagnosis. We've tended to recommend 2 different evaluation scales, the SCARED, the SCARED, and the GAD-7. So the SCARD is actually can be administered both to the parent as well as to the child, as long as the child is at least age 8. The GAD-7 is generally thought to be empirically validated for kids who are 12 and above. But and they have different sort of strengths. So the GAD-7, which I'll show you quickly here, this is a very quick screen. It doesn't take much time. It's easy to complete, and it's easy to score. And it mostly talks about symptoms related to generalized anxiety disorder. The SCARED is quite useful in other ways because it actually tries to cover the gamut of anxiety disorders that are commonly seen in children and adolescents. So it does cover generalized anxiety disorder. It also covers panic and panic disorder. It covers separation anxiety disorder symptoms. It covers social anxiety disorder symptoms. So, it really goes further than the GAD-7. The other thing about the SCARED is that you can get scales both for the parent and the child, and you can kind of compare them. What's the child reporting? What's the parent reporting? Do they line up in terms of symptoms? Are they very discrepant in terms of symptoms that are reporting? So the downside to the SCARED is that it's longer and it's a little bit more challenging to score. But there's a lot of valuable information in the SCARED once you move to the evaluation stage. So when we ask people to complete either the GAD-7 or the SCARED, we also want to make sure that the respondent, whoever has filled it out, has actually done looked at it and read it and made sure that the responses are valid. And then we're going to be thinking in terms of differential diagnosis. So not everybody presenting with anxiety is necessarily coming with an anxiety disorder. Some important things to consider in terms of differential diagnosis are what we call adjustment reactions, meaning that somebody is experiencing a lot of anxiety as a reaction. It's a short-term reaction to stress. That may not be the same as somebody coming with an anxiety disorder. Anxiety symptoms often overlap with mood disorders like depression. There are some particular medical disorders that can mimic symptoms of anxiety. So an example of this might be hyperthyroidism, where people are feeling jittery and hyperactive, and that actually isn't necessarily related to an anxiety disorder. It could be a medical disorder. There are people who react with different features of anxiety to starting new medications, especially medications that can penetrate the blood-brain barrier and cause anxiety or jitteriness or a sense of unrest. And that may be symptoms more related to a medication reaction. And especially in teenagers, giving consideration whether the anxiety symptoms are really an underlying issue with substance use, either showing symptoms while they're intoxicated or showing symptoms while they're in between using their substance, such as alcohol withdrawal or marijuana withdrawal, things like that. So those are two evaluation tools. Obviously, you're going to interview the child and the parent as well to get a sense about what's going on and really hopefully make a determination about whether the primary problem you're seeing is an anxiety disorder or some other issue that we just talked about. And then, giving it your best formulation. So again, here are the scoring and interpretation of the SCARED. A total score on the SCARED of 25 or higher indicates the possible presence of an anxiety disorder. Scores of 30 or higher are more specific. And, people have used the SCARED, understand that the different items are broken out along different diagnoses. So 7 items are indicating panic and somatic symptoms. 9 items are for generalized anxiety disorder. There are 5 items for separation anxiety disorder, 8 items for social anxiety disorder, and then 3 items for significant school avoidance. Kids who are not going to school, not all of them are severely anxious, but a substantive number of kids presenting with significant school avoidance or school problems are experiencing clinically significant anxiety. The cutoff on the GAD-12 for youth is considered 11 or higher on the scale, with scores of 17 or higher, indicating severe anxiety levels. So we've gone through screening, we've gone through evaluation. So clinical interview, medical evaluation using the empirically supported scales to help with getting a good diagnostic formulation. And then also looking to assess for what we call red flags that could affect your treatment planning. So the red flags that we're talking about, is there any signs of acute suicidality? Somebody's at risk for hurting themselves or committing suicide. Is anybody showing signs of psychosis, loss of reality, hallucinations or delusions? That again would be considered a red flag. Some kids present with severe anxiety during active trauma. And again, that should be a red flag. If somebody is actively at risk for being traumatized or in a situation where trauma is directly in their environment, that's a red flag. And kids who are actively using or abusing substances, again, red flags. Red flags means that we probably can't just think that we're going to approach kids the same, that they might need more acute interventions, crisis interventions, acute referrals for psychiatric consultation or treatment in the aspect of trauma, getting DCF involved to protect the child, substance use problems, especially if it's gotten to the point of substance dependence, might need detox interventions. So those red flags obviously have to be evaluated to make sure that a urgent referral to care is not needed. If there are no red flags and we do make the diagnosis of an anxiety disorder, then for the most part, most anxiety disorders are going to be treated as outpatients using different interventions. In terms of clinical decision-making, if we do a good evaluation and we make the determination that the anxiety symptoms are either subclinical or mild, sometimes we don't do anything active. We might wait and monitor folks and give people some self-help advice, some general ideas about how to manage stress and deal with stress. And sometimes that's enough. You want to follow those kids and families to make sure that the symptoms get better over time. So you might want to book a follow-up appointment, but sometimes in the subclinical to mild cases, guided self-management with follow-up in the primary care provider's office is maybe enough to weather the storm, and maybe those kids don't need to be referred. Moderate anxiety or unsuccessful self-management, usually the first step would be referring for therapy. You'll hear from me that I think CBT is the best CBT is cognitive behavior therapy. It's the best type of intervention for kids with significant, clinically significant anxiety. Sometimes it's hard to get, people who really practice CBT. Some kids will respond to other types of therapy intervention, but, when you get to the level of moderate anxiety or kids who are not responding to self-management, usually it's an indication that we have to think about an active intervention. Therapy certainly being one active intervention, and then at least giving some consideration for medication treatment. Severe forms of anxiety are usually going to be need specialty care for specific types of psychotherapy and or medication management until they're stable. Severe anxiety can be highly compromising and actually disabling, sometimes temporarily, sometimes much longer periods of time. And the earlier we get going with treatment, the better the outcomes are going to be in general. Okay, so again, the primary care provider is not necessarily going to be somebody who's going to be doing the psychotherapy, but you could be called upon to provide medication treatment in the moderate cases. And I'd say that probably some of the folks on the call have been asked to be involved with maybe the moderate, a little bit more than moderately affected kids as well. So we did want to give some advice for medication selection support. It's interesting when we think about the different psychiatric medications that are available in terms of non-obsessive compulsive disorder, non-OCD anxiety. The only medication that's actually FDA approved for kids is duloxetine or Cymbalta. And that's not a medicine that's it's not first-line medicine in our MCPAP clinical guidelines, and it's not in any pediatric anxiety clinical guidelines. It just happened that the company who makes duloxetine, which is Lilly, tested it and found it to be effective. And got FDA approval for it. But again, you're not going to see from our guidelines that duloxetine is actually going to be in it, except in more specialized cases. So we would follow the best evidence that we think is available, and we would recommend using either sertraline or Zoloft or fluoxetine, also known as Prozac. And those are the medicines that have the best research support for effectiveness in pediatric anxiety. As in all cases, we generally, for kids, we recommend starting low doses and like a daily test dose for 1 to 2 weeks, just to see how the kids react to the medications. We would recommend for kids with anxiety 5 milligrams of fluoxetine or 12.5 milligrams of sertraline. The smallest sertraline pill is 25, so you have to break the 25 in half, or use a liquid form. The smallest fluoxetine pill is 10 milligrams, so you have to break the 10 milligram pill in half to get 5 milligrams. But conservative dosing, I think, is appropriate for kids with anxiety disorders. Kids with anxiety disorders and families where anxiety is a prominent feature are often looking for threats. You know, it's just one of the features of anxiety. People with significant anxiety are very prone to threats, and the internal reaction of a negative side effect can be very threatening to kids and families. So we try to minimize the risk for developing side effects by starting with low doses, particularly for kids and families where there's a lot of anxiety in the family.
Hey, Bruce, we have a question on the chat about age, and what you would consider to be the youngest age for prescribing SSRIs for kids with anxiety disorders. I know that there's a separate issue about FDA approval,
right.
But I wonder if you could address that.
Yeah, I would say in general, I mean, I think that most of the child psychiatrists, the younger the age, the more conservative we are with medications. So like in the CAM study, we accepted kids down to the age of 7. Rarely would we be treating kids under the age of 7 with anxiety. That doesn't mean never. With kids with really bad anxiety, I prescribe medications for kids younger than that. It's a little bit more specialized. The dosing, I think, gets even more conservative. And I would say that it would be, in general, rare to start medication in a very young child who has not had a decent course of psychotherapy to try to help as a first-line intervention. But, I mean, I've treated several kids in my practice between the ages of 7 and 11 for anxiety symptoms. They can present with, especially the younger kids can present with separation anxiety and social anxiety. So, young kids, I mean, again, the preschoolers and the toddlers, you're probably not going to be using medication. Again, it would be very unusual. But, the school age kids, I think they were part of the CAM study. And so we have a certain amount of evidence support that those kids do respond to SSRI medications for severely compromising or troublesome anxiety symptoms. Gradually, we would be increasing the dose depending on both tolerance and therapeutic effectiveness. We generally recommend start low, go slow. Dosage adjustments for anxiety no faster than every 2 weeks, and then monitor on a weekly basis for agitation, suicidality, side effects. Again, with the black box warning is applicable for SSRI medication for anxiety, that there's a very small number of kids who have adverse psychiatric reactions to use of SSRIs, meaning that they can have a paradoxical reaction. The symptoms get worse, they don't get better. And then some of the kids have developed suicidality. So you have to monitor that, make sure the parents are aware of that. And if they're starting to see that, that's not what we're hoping for. That's the opposite of what we're hoping for. So people who are not getting better, having severe adverse reactions, maybe not tolerating the medicine. So we may have to get them off that medicine and then give consideration to other interventions. And any time that you run into any questions about medications, treating anxiety, feel free to give the McPap child psychiatrist on call a call so that you can discuss any kind of questions or concerns. Usual therapeutic dose range for kids with non-OCD anxieties disorders, fluoxetine is 10 on the low side, 60 on the high side. I don't generally go higher than 60. And I don't generally get to 60 for the most part, but it's a reasonable dose range. Sertraline has a much wider therapeutic dose range, starting with 25 milligrams on the low side, 200 on the high side. It makes it a little bit more challenging to use because you have more dosing steps that you potentially can go through. Most of the evidence-based information suggests that we need to do close monitoring during the initial phases of treatment. Suggested dose escalations, again, every 2 to 4 weeks based on both medication tolerance and therapeutic response. And we do, in certain cases, use what are called PRN medications for breakthrough acute anxiety. We would tend to recommend, and I think we've certainly seen it in Western Mass, that some of the primary care doctors have moved to prescribing medications such as antihistamines, hydroxyzine, or diphenhydramine for acute anxiety to be used as needed. And generally, we would rarely be thinking about benzodiazepines for kids and adolescents. We tend to stay away from them.
Hey, Bruce, a couple of questions in the question box.
Yep.
So if you go back a slide to the medication slide, yeah, that's it. So one question was about the use of a third SSRI. So one of the participants, Sue Fan Lin, wondered why you would suggest moving over to duloxetine rather than moving on to citalopram or escitalopram, in the algorithm.
Well, I think I would say that there's general consensus that if kids don't respond to or don't tolerate the first SSRI, then to try a second SSRI of a different kind. So I think there's general consensus about that. What you do after the failure of 2 SSRIs or intolerance of 2 SSRIs is less clear. Some people would try a third SSRI. To try, again, if it was an issue with tolerance, try to find one that somebody could tolerate and give a good therapeutic trial.
Right.
Duloxetine is mainly up here just to kind of say it's FDA supported, but it's not really a medicine that's going to be in our clinical algorithm. So we probably, again, third line medicine, we probably wouldn't be recommending duloxetine. It's an option if you follow FDA guidelines. But we would probably be thinking about either a third SSRI or an SNRI, possibly duloxetine. It's a therapeutic option, but it's not necessarily the only option as a third line medicine.
And then another question from Jamie Kerr, who asked if your recommendation about the initial weekly monitoring for starting SSRIs would be different for older kids, say 16 to 18, or is it sort of cut across the developmental spectrum?
Well, I think close monitoring is across the developmental spectrum. I mean, it's hard to do weekly monitoring, especially in-person monitoring. A little bit easier these days, maybe with telehealth, but phone calls from the nursing staff checking in on kids and families to see if they've had any kind of problems or difficulties. That's probably more doable. I think in general, we want close monitoring. That isn't the same as having the kids come in and see an in-person visit every week. I mean, that's practically challenging for any kind of practice, whether it's specialty care or primary care. I mean, the other thing which is always important is to make sure, which I tell families and kids and parents all the time, they're having a problem, just call us. We want to know about it right away. So make sure even if it's between visits or it's between phone check-ins, call us and let us know, because we can help sort out what the issue is and what the right thing to do is. So I would generally say close monitoring. Some of it's going to be in person, some of it's going to be phone check-ins. Whatever your practice can arrange. But I mean, generally think about close monitoring, I think is
I
important.
guess one more question, Bruce, before actually there's a couple. Judy Tapper asked about just the pace of titration for SSRIs. We do have on the algorithm a 2 to 4 week interval for considering titration, and for both depression and anxiety. And she wonders if there's any differences between using SSRIs for anxiety versus depression, whether or not we could, sort of have a different interval, in terms of considering dose adjustments.
Well, I think 2 to 4 weeks gives you a bit of latitude, and I do think that sometimes, when kids are severely ill, either with depression or anxiety, you tend to want to move quicker because you want to get the therapeutic effects better, and sometimes there is a dose aspect of it. I think especially for anxiety patients, though, you don't want to go too quickly, because if you set off side effects that could be avoided with a slower dose adjustment, sometimes that will trigger a rejection of medication treatment in general. So just because, again, it becomes a threat, and medication becomes a threat, and it makes the anxiety situation worse. So I think there's some leeway. You don't want to move too fast. You want to monitor things, and it's hard to do it by cookbook. Sometimes it requires like a check-in to kind of see how things are going before you make the next dose adjustment.
Yeah, I find I agree, and I find that with anxiety disorders, sometimes there's kind of more of a sense of urgency, because even though depression is usually more dangerous than anxiety disorders, the degree of internal distress and expressed emotion oftentimes with anxiety disorder is higher, and so I think we're sometimes under pressure to titrate more quickly, but I agree with you. I think it's good to kind of try to pace it very carefully, because you can really get ahead of yourself. And I think we put down 2 to 4 weeks, but I'm usually more inclined to give 4 weeks, when I titrate for both, anxiety and depression. So another question about Buspar, Bruce. People are wondering about your thoughts about Buspar.
Buspar is FDA approved for adults with anxiety, all different types of anxiety. It's used in kids. There's really haven't been any very good studies of Buspar in kids. I've had some clinical experience with it, and as a third or fourth line agent, certainly not in the first line. As a specialist, I've also used Buspar as what's called an augmenting agent for kids who get partial benefit from SSRIs. I've added low dose buspirone or moderate dose buspirone as a combination approach to try to augment SSRIs. That's, again, I wouldn't recommend that for primary care. That's much more for specialty care. If it works, it should be demonstrated in studies. There just haven't really been good studies of buspirone for kids, unfortunately.
I got one more. These are really good questions, by the way, for the audience to know. So there's a question about the gene testing, the topic unto itself. In fact, we did have a clinical conversation session about a year ago from Dr. Lisa Namaro, who is a content expert. She runs, she's involved in a McPAP type program in Connecticut at the Hartford Hospital. But what are your thoughts, Bruce, about gene testing, particularly GeneSight? And I think there's another vendor that has a similar kind of service that they provide.
Yeah, so it's my short answer to the question is the American Academy of Child and Adolescent Psychiatry put out a statement about a year ago, March of 2020, about pharmacogenetic testing and use for medication selection for kids. They actually It was a complicated statement, but they had two major components. One is that they're a big fan of research because we need to learn more about this, and there may be something very valuable for patients. But in terms of clinical practice, they actually discourage it, because the evidence base for using the gene site testing is not there. Sometimes the gene site testing results will indicate choice of medications that are not in keeping with clinical guidelines. That's a potential danger. If you say, well, the gene says I should use Prestique for this, and then, but you haven't gone through sort of a regular clinical guideline treatment with SSRIs, that can be a danger. So I'm a big fan of clinical guidelines. I'm a big fan of research with pharmacogenetic and pharmacodynamic testing. It may be something down the road that's going to be very valuable to us, but I continue to say I don't think it's ready for prime time for clinical practice, so I tend to discourage it. So I'm right in keeping with the American Academy of Child and Adolescent Psychiatry where they are at on this one.
Great, thank you, Bruce.
All right, let's see, what else do we have? So follow-up and monitoring, we definitely recommend follow-up and monitoring support, following up 4 weeks, doing another check-in with whatever tool you're measuring with, the SCARED and the GA7, to see if we start to see symptomatic improvement, if we start moving in the right direction, continuing the medication at least for a few months to try to consolidate gains and help the kids develop better functioning, help them learn to cope with the anxiety. Again, following up every 4 weeks using the same measurement tool. Note one here is if distress and impairment are severe, we can increase fluoxetine up to 30, 40, 50, whatever we need to, but usually spaced out with some interim, and again, not to move too fast. Sertraline, again, has the wider dosing range. We can get to 100 milligrams, even up to 200 milligrams, but not moving too fast. If the distress and impairment score remains relatively unchanged after extended treatment, or the youth remains severely affected with no treatment response, please consider a MCPAP phone consultation or even a face-to-face consultation at that point. Reassessment at 12 weeks. If things are in a good place, we're going to start talking about continuation treatment, at least for a few months, with ongoing monitoring over that time. And, if kids are been on medication 6 to 12 months, doing well, maybe making gains in psychotherapy, and the family starts to wonder, can I come off this medication? I generally say yes, kids are not going to stay on medication the rest of their lives. When things are better and we feel confident, I think about the timing of when we're going to try a medication taper or discontinuation and monitor closely for symptoms at that point. But yes, hopefully we can get most of the kids after they've been on it for a period of time and they're doing well, to try to get them off medication down the road. We don't want them necessarily to take it for the rest of their lives. And then the most important thing I say to people is if we're thinking about coming off medication, you're still in treatment, we got to follow what happens, because if the symptoms come back, we might want to go back on medication for a period of time. If the symptoms stay away, then you might not need medication. But that period of time, when you've made the decision to taper the medication and then see if you can discontinue it, it's very important to follow kids and families during that period of time to make sure that if the symptoms relapse, we have a plan for what to do at that point. Again, the algorithm's not going to be the best starting point for the severely ill, treatment-resistant, or highly complicated presentations. And providers should be feel free to make use of MCPAP consultation, phone consultations, face-to-face consultation with any challenging clinical questions or clinical situations. And that's all I have. So thank you. Any further comments or questions?
So thank you, Bruce, so much. There is another question in the chat about L-methylfolate, which I understand there is a bit of evidence for using that as a supplement to enhance the effectiveness of SSRIs for depression in adults. But I wonder if you have any opinions about that, or even if you want to get into the area of supplements and diet and vitamin D and things like that.
Yeah,
Well.
I would say, I mean, again, we've tried to make the algorithms evidence supported, and that's why we're updating them every couple of years. I would say that L-methylfolate has not made it into the evidence base for kids with anxiety. Some people would say, well, it probably is not going to cause harm, and some people might benefit. And you could say similar things about other types of dietary supplements. You do have to be careful about what's in the supplements and make sure it's not interacting with SSRI medications. So St. John's worts actually can interfere with metabolism of some SSRIs. So you have to be somewhat careful. I'm not going to say anything about L-methylfolate, mainly because there isn't a lot of evidence to say one way or another. So it wouldn't be in our algorithm, and we try to keep in our recommendations things that have good to very good empirical support.
Thank you. So there's another question, I think, kind of related to the frontiers and the margins in psychiatry is the use of marijuana or cannabis for anxiety disorders. It's a very practical question because many of our patients are self-medicating, with or without the guidance of their providers, with cannabis. And there are many patients who are convinced that it helps them. But what are your thoughts about that, Bruce?
Well, I would say that if you ask certain individuals, they would say, yes, absolutely. It helps me quickly. It makes me feel better. It's one of my stress coping techniques, and it's sometimes it's hard to convince people otherwise. I mean, I don't know that I would spend much time trying to convince somebody not. I mean, I do worry about the effects of marijuana. Marijuana is potentially addictive. I mean, people will say, well, it's never addictive. It's not, you don't get the same kind of physical withdrawal symptoms as you might get from like alcohol or barbiturates. But, the National Institute of Drug Abuse on their website will say marijuana can be addictive. People who are younger when they use marijuana can get addicted easier. Addiction usually represents a state where people are struggling functionally in their lives. They're spending too much time smoking marijuana, and it's impairing their relationships, impairing their work, impairing their education. So I'm not a big fan of using marijuana for anxiety, and in fact, I try to discourage it as much and try to educate kids as much as possible.
Yeah. Especially, I mean, as you say, for the pediatric population, for sure, but also for adults. So in pediatrics, there is a good evidence base that cannabis is actually harmful to children and young people. There is not necessarily as good of an evidence base that it's harmful, for adults, depending if they're not, addicted, but there is a rate of addiction, for cannabis, in both adults and kids. So I think that the point is, that we really don't have evidence, that this is effective, and we have good evidence that it actually is potentially quite harmful, particularly for the pediatric and the adolescent, population. So I agree with you. I discourage this, pretty definitively. But you do have to take motivational interviewing approaches, because people, sort of have the power to, oftentimes to do what they see fit, and so we have to think about how we try to be good influencers. Well, I think we've come just about to the end of our time. And so I want to thank you, Dr. Waslick, so much for this excellent presentation. I want to thank the audience for the great questions and for their attendance. I do want to remind people to fill out their quickie questionnaire that will pop up once you end the presentation. and to see people next month.
Barry, it's John.
Yes, sir.
One quick
John.
thing. Someone asked a question about whether we're going to reprint all the books with all 6 algorithms in them now. And the answer is yes. It's nice to hear that someone likes them, and we will be doing so over the summer.
Yes, indeed. Thanks, John, for reminding me about that. All right. Well, see everybody next month. And thanks again, Dr. Waslick.
All right. Thanks, everybody. Bye-bye.